All right, today we're diving into a medical case file from Dr. Hazrat Bilal and his team. And let me tell you, it's a tragic story for sure, but it's also a fascinating detective story. It really uncovers some of the hidden dangers that can lurk behind our most advanced and life-saving cancer treatments. Picture this. A 47-year-old man, he walks into a hospital with what seems like a fever and some stomach pain. Just 1 week later, he's gone. Now, this isn't just about one patient's incredibly rapid and heartbreaking decline. It's a critical lesson from modern medicine, a real warning about the invisible enemies that can creep in when we're focused on fighting other battles. So what on earth happened in those 7 days? I mean, how could a situation spiral out of control that fast? And really, the most important question is, what can we all learn from this tragedy to make sure it doesn't happen again? Okay, let's get into it and follow the chain of events. You have to understand this didn't just happen out of nowhere. It wasn't one single problem. It was this convergence of 3 major risk factors that, altogether, created the absolute perfect storm for a deadly infection to take root. So first, he was living with chronic lymphocytic leukemia, CLL, which is a blood cancer that, by its very nature, weakens the immune system. Then he was on a really cutting-edge targeted therapy for it, called zanubrutinib. And to top it all off, he was also dealing with uncontrolled diabetes. Any one of those is a serious health challenge. All 3 together, it made him profoundly vulnerable. And right into that perfect storm stepped this deadly opportunist, Mucormycosis. Now, this is not your average fungus. It's an aggressive, incredibly fast-moving predator that specifically goes after hosts whose immune systems are down and whose blood sugar is high. Tragically, this patient was its perfect target. And here's where it gets really interesting when we talk about the drug zanubrutinib. It's a type of drug called a BTK inhibitor. And it's a modern marvel, really. It has transformed how we treat cancers like CLL. But it comes with a huge trade-off. While it is brilliant at shutting down cancer cells, it can also hamstring the very immune cells you need to fight off an infection. So the treatment that was keeping his cancer at bay was also essentially disarming his body's security guards. Okay, so we've got the setup, a vulnerable host, and a really invasive fungus. Let's look at the timeline of his hospitalization, because it reveals this frantic 1-week race against an enemy that, for pretty much the entire time, was completely invisible to his doctors. He gets admitted on November 7th. Just 3 days later, his spleen completely loses its blood supply, and they have to rush him in for an emergency removal. But his condition just keeps getting worse. So by November 12th, they send a sample for this cutting-edge genetic sequencing, just hoping for an answer, any answer. But it's too late. The very next day, he dies from multi-organ failure. So, the medical team did what you'd expect. They went right after the most obvious problems, that failing spleen and a suspected bacterial infection. They hit him with powerful broad-spectrum antibiotics. And it was a completely logical first move. But the problem was, while they were fighting that battle, the real enemy was just multiplying, completely unchecked. And this is where the story takes a really tragic turn. Because what makes this case such a powerful lesson is that a critical clue was right there from day one. It was hiding in plain sight on the very first set of scans they took. And take a look at this, because this illustrates that clue perfectly. This is the chest CT from the day he arrived at the hospital. That arrow is pointing to a little spot in his lung. It's a nodule with what's called a reversed halo sign. Now, in a patient who is immunocompromised, that sign isn't just a clue. It is a blaring 5-alarm fire bell for an invasive fungal infection like mucormycosis. But, and the case report points this out directly, this critical sign is often missed. The doctors were, and you can understand this, completely consumed by the emergency happening in his abdomen, that splenic infarction. That immediate crisis totally overshadowed the slower, quieter, but ultimately just as lethal threat that was brewing in his lungs. So, with the patient fading and the antibiotics doing absolutely nothing, the team played their last card. They sent a sample for what's called mNGS. It's a high-tech sequencing tool that can find a pathogen's DNA. But in a race this fast, technology can't always keep up. The test took time, and time was the one thing he just didn't have. Tragically, despite everything the intensive care team could do, from mechanical ventilation to escalating drugs, the infection had just spread too far, too fast. The patient passed away from multi-organ failure. And the final, definitive answer, it arrived after he was gone. The advanced sequencing results came back, and they finally put a name to the killer. a specific type of fungus called Rhizomucor pusillus. The unseen enemy finally had a name.
So, we get to the most important part of this whole story. What do we do with this information? What are the clear, actionable lessons we can take from this tragedy that could save another patient who finds themselves in the exact same situation? Let's just compare the path that was taken to the recommended path. After his surgery, the team added an antifungal called fluconazole. But here's the devastating problem. Fluconazole has absolutely zero effect on the kind of fungus that was killing him. The recommended path? The moment a fungal infection was suspected, they should have started liposomal amphotericin B, a totally different, much more potent drug. And I really cannot overstate this. In this kind of fight, choosing the right antifungal isn't just a detail, it is the entire battle. For suspected mucormycosis, the standard of care is liposomal amphotericin B. Using the wrong drug, even with the best intentions, was like bringing a water pistol to a house fire. So the takeaways from this are crystal clear. Clinicians have to be extra vigilant for these kinds of fungal infections in any patient on these new cancer drugs. They cannot overlook subtle radiological signs like that reversed halo. They need to use advanced diagnostics early, not as a last resort. And most importantly, if you even suspect mucormycosis, you start the right therapy, liposomal amphotericin B, immediately. You just don't wait. And that really leaves us with this final, crucial question. As our medicines get smarter and more powerful, they create new and sometimes unexpected vulnerabilities. This case is a stark reminder that as medical science takes these huge leaps forward, our vigilance for the dangers that can ride in its shadow has to advance right alongside it.